You have been told your whole adult life that the gold standard blood pressure is 120 over 80. You have seen it on posters in waiting rooms. You have heard it from nurses taking your reading. You may have spent years trying to achieve it or felt alarmed when you could not. And if you are over 65, I am here to tell you that this number, as a universal, context-free target, is not just incomplete. For your age group, it can be actively misleading, and in some clinical scenarios, aggressively pursuing it can be more dangerous than the blood pressure you are trying to lower. That is not a fringe position. That is where the peer-reviewed evidence has been moving for the last decade, and most patients never hear it because clinic visits do not leave time for the nuance. Let me be precise about what I mean, because this is not an argument against treating high blood pressure. Hypertension is the single most modifiable risk factor for stroke and one of the most important modifiable risk factors for heart attack, heart failure, and kidney disease. Treating it saves lives. The lie, and I will use that word deliberately, though it is a lie of omission rather than malice, is the idea that 120 over 80 is the right target for every person of every age. It is not. And understanding why it is not and what the actual evidence-based targets look like for different clinical presentations is knowledge that belongs to every patient, not just to the cardiologist managing complex cases. If you want medicine explained at this level, where the clinical nuance is in the hands of the patient, not locked behind medical jargon, subscribe, hit the bell, join a community that treats you as a capable adult who deserves the full picture. The patient I want to describe was 79 years old. He had been hypertensive for 20 years, well managed on 2 medications, with a typical clinic blood pressure running around 145 over 85. His new cardiologist, following updated guidelines that promoted more aggressive systolic control, up-titrated his medications to bring his blood pressure closer to 120 systolic. Over the following 3 months, he fell twice. The first time, he was rising from a chair. The second time, he was walking to the bathroom at night. The second fall fractured his hip. He required surgery, spent 6 weeks in rehabilitation, and left with a functional decline from which he never fully recovered. His blood pressure was beautifully controlled at 118 systolic. He never had a stroke. He lost his independence. This is not an anecdote about one cardiologist making a bad decision. It is a clinical pattern documented in the literature with a specific name: orthostatic hypotension-related falls. And it is directly relevant to the question of what blood pressure target is appropriate for older adults. Here is the biology that explains why blood pressure physiology changes with age and why the same number means different things in a 50-year-old and a 75-year-old. The arterial system is not a simple pipe. It is an elastic, dynamic structure that absorbs the pulse wave of each heartbeat and smooths out the pressure delivered to the capillaries. The elasticity of the arterial wall, maintained by elastin fibers, is what allows this buffering. With age, elastin breaks down and is replaced by stiffer collagen. The result is arterial stiffness. The technical term is arteriosclerosis, distinct from atherosclerosis, which is the plaque process. Arterial stiffness has 2 consequences that are directly relevant to the blood pressure number. First, the systolic pressure, the peak pressure during each heartbeat, rises because the stiff artery cannot buffer the pulse wave as effectively. Second, the diastolic pressure, the pressure between beats, may actually fall because the stiff artery does not recoil and maintain pressure between beats the way an elastic one does. The result, very common in older adults, is a wide pulse pressure, high systolic, normal, or low diastolic. And this is a fundamentally different hemodynamic situation from the combined elevation of systolic and diastolic that characterizes hypertension in younger adults. Now, here is where the target number becomes complicated. In an elderly patient with isolated systolic hypertension, elevated systolic with normal or low diastolic, Aggressively lowering the systolic with medication also pulls the diastolic lower. Research from the INVEST trial and multiple observational analyses has documented a J-curve phenomenon. Below a diastolic threshold of approximately 60 to 65 millimeters of mercury, cardiovascular event rates, including heart attack, begin to rise again, not fall. This is because the coronary arteries, the vessels supplying the heart muscle itself, fill during diastole, not systole. The heart works during systole and fills its own blood supply during the relaxation phase. When diastolic pressure falls too low, coronary perfusion is compromised. In patients with coronary artery disease, common in this age group, diastolic blood pressures below 60 are associated with increased cardiovascular risk, even when the systolic target has been achieved. Drop your age in the comments right now. This matters enormously for the specific guidance that applies to you. Under 60, the evidence for tight blood pressure control, targeting systolic below 130, is strong, and the risks of achieving it are generally manageable. Between 60 and 75 in otherwise healthy individuals, the SPRINT trial showed benefit from targeting systolic below 120, but this trial excluded patients with diabetes, prior stroke, and significant kidney disease, meaning its results do not necessarily apply to people with those conditions. Over 75, the picture becomes considerably more nuanced. The HIVIT trial, hypertension in the very elderly trial, showed benefit from antihypertensive treatment in adults over 80 with systolic pressures above 160, but the treatment target was 150 systolic, not 120. The SPS-3 trial, ACCORD trial, and observational data from multiple cohort studies collectively suggest that in frail older adults, in those with orthostatic hypotension, and in those with multiple medications and comorbidities, aggressive lowering below 140 systolic carries risks that may outweigh benefits in individual cases. Mistake 1. Applying a universal blood pressure target without accounting for frailty and fall risk. This is Tier 1. The American Geriatric Society has specifically recommended that blood pressure targets in adults over 75 should be individualized based on frailty status, fall risk, cognitive function, and comorbidities, not applied uniformly. Frailty, defined clinically by criteria including unintentional weight loss, exhaustion, low grip strength, slow walking speed, and low physical activity level, is associated with blunted baroreceptor reflex sensitivity. The baroreceptor reflex is the automatic mechanism by which the body adjusts blood pressure when you change position, from lying to sitting, from sitting to standing. In frail older adults, this reflex is sluggish. Blood pressure drops when they stand up before the reflex can compensate, producing orthostatic hypotension, dizziness, and fall risk that is directly worsened by aggressive antihypertensive medication. Mistake 2. Measuring blood pressure only in the clinic and treating that number as definitive. This is clinically critical and Tier 1. White coat hypertension, elevated blood pressure in the clinical setting that normalizes at home, affects approximately 15 to 30% of patients diagnosed with hypertension, according to research published in Hypertension Journal. Treating white coat hypertension as real, sustained hypertension is unnecessary and potentially harmful. The inverse, masked hypertension, where clinic readings are normal but home readings are persistently elevated, is equally important and missed when only clinic readings are taken. Research published in the Journal of the American Medical Association has shown that home blood pressure monitoring is a better predictor of cardiovascular outcomes than office blood pressure in most age groups. A validated home blood pressure monitor, used correctly with the cuff at heart level after 5 minutes of seated rest before morning medications, provides the most clinically informative data. The best clinical picture comes from averaging readings taken twice daily for 7 days. Mistake 3. Ignoring morning blood pressure surge. Blood pressure follows a circadian pattern, lowest in the early morning hours before waking, rising sharply with the cortisol awakening response in the first 1 to 2 hours after waking, reaching a morning peak, then declining through the day. Research published in Hypertension has identified the morning blood pressure surge, the rapid rise from the overnight nadir to the morning peak, as an independent risk factor for stroke and cardiovascular events. This is mechanistically coherent. Stroke and heart attack rates are highest in the early morning hours, precisely the period of maximum blood pressure surge, combined with increased platelet aggregability and blood viscosity after overnight fasting. If your blood pressure is controlled in the afternoon but elevated at 7 a.m., a pattern that requires morning readings to detect, your cardiovascular risk is not well managed. Once-daily medications taken in the evening may provide better morning coverage than those taken in the morning for this reason. Research from the TIME study, a large randomized trial published in The Lancet, investigated morning versus evening timing of antihypertensive medications and is informing this clinical question, though the benefit of evening dosing is tier 2 in terms of certainty. Mistake 4. Treating the number without treating the mechanism. Blood pressure elevation is not a disease, it is a signal, the downstream consequence of one or more specific physiological dysfunctions: arterial stiffness, excessive activation of the renin-angiotensin-aldosterone system, sympathetic nervous system overactivation driven by chronic stress, sleep apnea, or obesity, sodium retention from excessive dietary sodium, kidney dysfunction, or aldosterone excess. Primary aldosteronism, a frequently missed condition in which a benign adrenal adenoma produces excess aldosterone, causing sodium retention and hypertension, is now estimated to account for 5 to 10% of all hypertension cases, a figure dramatically higher than historical estimates, based on research published in the Journal of Clinical Endocrinology and Metabolism. Most of these patients are treated with blood pressure medications that manage the number without ever identifying the mechanism. When the mechanism is found and treated, in the case of primary aldosteronism with surgical removal of the adenoma or targeted medication, the hypertension often resolves entirely. Mistake 5. Neglecting the lifestyle factors with the most evidence. This is tier 1 for each individual intervention. Dietary sodium reduction, specifically targeting below 1,500 milligrams per day in salt-sensitive individuals and below 2,300 in others, produces systolic reductions of 4 to 11 millimeters of mercury in hypertensive adults, based on data from the DASH sodium trial. The DASH diet itself, dietary approaches to stop hypertension, combining reduced sodium with high potassium, magnesium, and calcium intake from food sources, has produced reductions of 8 to 14 millimeters of mercury systolic in clinical trials, approaching the effect size of a single antihypertensive medication in mild to moderate hypertension. Aerobic exercise, 150 minutes per week of moderate intensity activity, reduces systolic blood pressure by 4 to 9 millimeters of mercury on average, with greater reductions in patients with higher baseline values, based on a meta-analysis published in the British Journal of Sports Medicine. Alcohol reduction, limiting to 1 standard drink per day maximum, is associated with 2 to 4 millimeter reductions in systolic pressure. Weight loss of 1 kilogram is associated with approximately 1 millimeter of mercury reduction in systolic blood pressure. Chronic sleep deprivation and untreated obstructive sleep apnea both elevate blood pressure through sympathetic activation, and their treatment is a legitimate blood pressure intervention. Mistake 6. Not understanding what both numbers mean. Systolic pressure, the top number, represents the peak pressure generated by each cardiac contraction. Diastolic pressure, the bottom number, represents the arterial pressure during the heart's relaxation phase. Pulse pressure, the difference between them, is itself a cardiovascular risk marker. A pulse pressure above 60 millimeters of mercury is associated with increased arterial stiffness and elevated cardiovascular risk, independent of the absolute values of systolic and diastolic. This means that a blood pressure of 160 over 90, pulse pressure of 70, carries a different risk profile than 140 over 100, pulse pressure of 40, even though the second patient has a higher diastolic. Understanding what you are measuring, not just whether the number falls below an arbitrary threshold, changes the entire conversation about treatment goals and intervention strategies. The evidence-based target for most adults with hypertension, based on current guidelines from the American College of Cardiology and American Heart Association, is below 130/80. For adults over 65 without significant comorbidities, this remains appropriate. For adults over 75 or those with frailty, orthostatic hypotension, multiple medications, or significant coronary artery disease, individualized targets, often 130 to 150 systolic, should be determined in conversation with a physician who knows the full clinical picture. The number on the cuff is data. What it means for you depends on your age, your vasculature, your comorbidities, your medications, and your fall risk. That is not a reason to avoid treating hypertension. It is a reason to treat it intelligently with the full clinical context in view. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. I want to go deeper on the specific medications used for blood pressure in older adults because the class of medication matters not just for the blood pressure reading, but for the additional benefits and risks it carries in an aging body. This is clinical information that patients deserve to have when they are discussing their treatment with a physician, and it is rarely communicated in a 15-minute appointment. The 5 main classes of antihypertensive medications each have distinct mechanisms and distinct profiles of benefit and risk in older adults. Thiazide diuretics, particularly chlorthalidone and hydrochlorothiazide, lower blood pressure by reducing sodium and water retention, effectively reducing blood volume. They are among the most studied antihypertensives in older adults, with evidence from the ALL-HAT trial, the largest antihypertensive trial ever conducted, with over 33,000 participants, showing chlorthalidone superior to other drug classes for preventing heart failure and stroke in a broad older adult population. However, thiazides can cause hyponatremia, low sodium, which in older adults produces confusion, falls, and in severe cases, seizures. They can also cause hypokalemia, low potassium, which increases cardiac arrhythmia risk and muscle weakness. Routine electrolyte monitoring is essential with thiazide use in older adults, and the dosing should start low. ACE inhibitors and ARBs, the angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, work by blocking the renin-angiotensin-aldosterone system, reducing arterial constriction and aldosterone-driven sodium retention. They have specific benefits beyond blood pressure lowering: kidney protection in diabetic nephropathy, reduction of protein in the urine, heart failure benefit, and some evidence for slowing of cognitive decline through their effects on cerebrovascular function. Research published in the Journal of the American Geriatric Society has shown that ARBs specifically may have neuroprotective effects beyond blood pressure control, which is an active area of investigation. The primary concern in older adults with these medications is a rise in serum creatinine, reflecting reduced glomerular filtration, which must be monitored, and elevated potassium, particularly when combined with potassium-sparing diuretics or in the setting of chronic kidney disease. Calcium channel blockers, amlodipine is the most commonly used, lower blood pressure by reducing the entry of calcium into arterial smooth muscle cells, causing vasodilation. They are particularly effective in isolated systolic hypertension, the elevated systolic with normal diastolic pattern common in older adults, because arterial stiffness rather than arteriolar spasm is the primary mechanism, and calcium channel blockers address the vascular smooth muscle component effectively. The ACCOMPLISH trial compared an ACE inhibitor plus calcium channel blocker to an ACE inhibitor plus diuretic and found the calcium channel blocker combination superior for cardiovascular event reduction. The primary side effects of amlodipine in older adults are lower extremity edema, which can be mistaken for heart failure, and, at higher doses, constipation. Beta blockers, atenolol, metoprolol, carvedilol, lower blood pressure primarily by reducing heart rate and cardiac output. They have specific indications in older adults with concurrent coronary artery disease, heart failure with reduced ejection fraction, or certain arrhythmias. As a primary antihypertensive in older adults without these indications, their role has been somewhat diminished by evidence showing they are less effective at reducing stroke risk than other classes, despite equivalent blood pressure lowering, possibly because they do not reduce arterial stiffness and aortic pulse pressure as effectively. Research published in The Lancet, specifically a meta-analysis by Dr. Lars Lindholm's group, raised questions about the use of atenolol specifically as a primary antihypertensive, and current guidelines generally recommend other classes as first-line agents for uncomplicated hypertension in older adults. Beta blockers also have specific concerns in older adults. They can mask hypoglycemic symptoms in diabetics, they can worsen peripheral arterial disease by reducing blood flow, and they can produce fatigue, depression, and reduced exercise tolerance. Mineralocorticoid receptor antagonists, spironolactone and eplerenone, block the effects of aldosterone and are particularly useful when primary aldosteronism is suspected, when resistant hypertension exists despite multiple other agents, and in heart failure with reduced ejection fraction. Research from the Pathway 2 trial, published in The Lancet, showed spironolactone superior to other add-on agents for resistant hypertension. The primary concern in older adults is hyperkalemia, elevated potassium, particularly in the context of chronic kidney disease or concurrent ACE inhibitor and ARB use. The practical message from this medication review is not that patients should be managing their own antihypertensive regimens. They should not. It is that patients who understand the mechanism of their medication, its specific benefits beyond blood pressure for their comorbidities, and its specific risks in their age group can have far more productive conversations with their physicians about whether their current regimen is the most appropriate one. If you are on a blood pressure medication and you have never been told why that specific class was chosen for you, that is a conversation worth initiating. There is also the question of medication timing and the interaction between antihypertensive drugs and other commonly used medications in older adults. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, interfere with the blood pressure lowering effect of ACE inhibitors, ARBs, and diuretics through prostaglandin-mediated mechanisms and can cause acute kidney injury when combined with ACE inhibitors and diuretics, particularly during dehydration from illness or hot weather. This triple whammy, diuretic, ACE inhibitor, and NSAID, is one of the most common causes of acute kidney injury in older adults presenting to emergency departments. If you take blood pressure medication and you regularly use over-the-counter NSAIDs for pain management, this is an important conversation to have with your prescribing physician. Decongestants, phenylephrine and pseudoephedrine, found in many over-the-counter cold and allergy medications, cause vasoconstriction and can acutely elevate blood pressure by 10 to 20 millimeters of mercury systolic in susceptible individuals. For older adults with hypertension, these medications warrant avoidance or caution, and saline nasal spray or nasal steroid sprays are safer alternatives for nasal congestion management. Let me bring this all the way back to the central message because it is important that it is clear. 120/80 is a useful reference point, a historical benchmark that has helped clinicians and patients think about blood pressure in a standardized way. It is not wrong, it is just incomplete. The complete picture includes your age, your arterial stiffness, your fall risk, your comorbidities, your medication burden, your morning blood pressure readings, your 24-hour blood pressure pattern, and the mechanism driving your hypertension, not just the number on the cuff. Getting that complete picture is worth asking for. Knowing how to interpret it is worth learning. And using it to have an informed conversation with your physician about your specific targets and your specific treatment is the exercise of exactly the kind of health ownership that changes outcomes. Blood pressure management in seniors is one of the areas of medicine where the gap between what the evidence shows and what the average patient understands is widest. You just narrowed that gap considerably.